I'm going to ask that our assistants help us and put the polling polls up for our continued attendees. We've created 3 questions for this session, which we will review at the end of a discussion of our teaching videos. Dr. Rapici was nice enough to include a number of his teaching videos in his presentation, but I do have additional videos by Dr. Rex and Dr. Waugh to review with you. So I think what I'd like to do at this point is ask Dr. Rex to join us and perhaps go to the beginning of his teaching video. Do not play it yet and let him give us a little introduction. Doug, go ahead.
Yeah, thanks, Steve. So hi, everybody. This is a case that I think is something we see in practice quite frequently. About 25% of our referrals for resection of lateral spreading lesions in the colon, there's been a previous attempt at resection. And as in this case, the resection is often of the anal side or the side on the anal side of a haustral fold, and it'll be sort of heavily scarred down. And so the problem here, I guess, is how to deal with this. And we have a variety of options, including underwater endoscopic submucosal resection, the full thickness resection device. I think this would be a little bit big for the full thickness resection device because there are the issues of both fibrosis and then just the size of the lesion to get it into the device versus conventional EMR and the addition of some technique to get the disease off the fibrotic part, realizing, as we talked about, we don't want to ablate anything that is flat and not removable with the snare, but rather we'd remove it by another technique. And I'll nicely show the use of the cap in this situation. And I'm going to rely on avulsion. I kind of like avulsion for most people in practice because I think it's technically quite easy to do. But why don't we roll the video and take a look at it. So I think this was in the hepatic flexure. It looks like it's maybe 20 to 25 millimeters across. And you can see a bit of the fold puckering at the distal edge of it. Almost always you can endoscopically see where the previous resections have been done because of the scarring. So I injected on the proximal side of it and then removed that part by EMR. And then we're going to demonstrate hot avulsion technique. And I like this because I think it's just so easy. It's the only time that I use hot forceps in colonoscopy. You want to be a little careful with how deeply you grab the tissue. I've only actually perforated doing this once, and that was in the transverse colon, taking some tissue right off the edge of a fold. The muscle does come up closer to the surface right under the folds. And the goal of this technique is to basically continue the resection in the same plane that you were snaring in. So this tissue right along the distal edge here is where there's a question. I think that's where the highest risk of recurrence is. So you can see we're overlapping one cup of the forceps in the submucosa by a couple of millimeters. That's about all it takes. Grab the tissue firmly and then mechanically stretch it. And then you just tap on cutting current. So we have this on endocut I, and you could see very nicely there at the bottom that we separated that tissue in the same plane that we had been resecting in. And of course, this kind of flat polyp and fibrosis occurs in lesions that have never had work done on them. We sometimes have to resort with avulsion, but we find that the use of the cap technique and avulsion are more commonly needed when there has been a previous attempt at resection. And then only after we've actually removed everything that looks like it could possibly be polyp, we want to go around and destroy the edge. And I actually usually use, for most lesions, use the snare tip on soft coag. Sometimes in these ones where there's been previous work done, I still use APC, which is an alternative. It's obviously more expensive, but the idea is that we're going to remove either with the cap or with the avulsion forceps everything that looks like it could potentially be polyp. And then we're going to go over what appears to be normal margin just to try and destroy every last cell along the margin of the lesion. So I'd be interested to hear what others would, how they might deal with that differently. But from my standpoint, in a situation where I think is pretty common in clinical practice, that just using simple tools, we typically can still resect these lesions. And I'm afraid from reading some papers that often, a partially resected lesion is still considered an indication for surgery. In reality, we can get almost all of these lesions off with relatively simple tools.
That's a great case, Doug. Thank you. I mean, what was the interval between the previous resection technique and your endoscopy? It seems like that was a fairly sizable lesion.
Well, so that again, what I think what often happens is that the referring physician removes part of the lesion and then just decides that they're in trouble in some way and they stop.
Right.
This is what we see a lot. And we do see some really crazy things sometimes, like people taking biopsies of lesions with hot snares, like it's going to somehow improve the situation for you. But I think what happens more often is that an endoscopist out in practice starts a resection and then, thinks that they're over their head and stops. And certainly in that circumstance, it's really important that these patients with benign lesions not be sent to surgery. Somebody around can take care of this. And often you'll be able to take care of it too, like I said, with, I think, relatively simple tools. So it wasn't really a recurrence from a clean scar, Steve, but rather just a partially resected lesion. And that's what we see the most of, actually, in this 25% of all of our referrals that are partly resected. And we do say to people a lot, it's better to just leave these lesions alone, to not touch them. Serrated lesions, you don't even need to biopsy them if you don't want to take them out. Flat adenomas, don't even biopsy them unless there are adverse histologic features, something that you think is cancer that might need to go to surgery. So
agree. I very much agree. And that, as you
Can I make a point?
Yes, please.
Oh, that beautiful video. So I think the other way to do these polyps, because it is definitely a challenging situation because of location, morphology, recurrence. The other way can be that before you get started with the resection, you create a mucosal incision with the tip of the snare about few millimeters out of the border of the lesion. So you create delineation of the area that you want to resect. At the end, with the residual tissue that you have left in between the cut, you can use the small cold snare, suck the tissue in, resect, and probably you can have even a little bit more histology. That can be another possibility of resecting that.
yeah, I really enjoyed your video, Al, where you were showing that technique, and I have used the cold snare technique for, the cap technique, I think is what you're discussing, right? The cap with the cold snare.
Cap section.
And it's one of the things that is different from the way I've always done it, and the way I see you doing it is you have the cap out further than I do. It looks like you have it out by 5, 6, 7 millimeters.
Bend ligation technique, that it's like bending. You have to suck in.
Right. And I first of all, I would caution people to be a little bit careful about that, because I think most of us are not as comfortable with perforation as you are, Al, and with dealing with it. But I saw in the recent European series that was in endoscopy that they, using their cap technique, they had, I think it was about a 7% perforation rate.
Right.
And, I use the cap and actually often use it with the snare and with electrocautery, but I don't put the cap out as far. I have it only out usually about 3-4 millimeters, and we don't get as much tissue, and we have a much lower rate of muscle injury. I have had a perforation with it, but I would just say, and I think another difference is that you're using the cold snare, which may bounce off, deeper tissue a little bit better. But I think this is an issue we need to settle, is how far that cap should really be out for the average person out there in the community to use it and use it safely. And I'm not sure yet what the answer is, but you should look at Al's videos. I've got some videos that are on the ASGE site, and there's a little bit difference in the depth of the cap, but I agree the cap can be an incredibly useful way to get a hold of fibrosis that you can't otherwise get a hold of with a snare.
One of the tricks to protect your resection and to avoid the perforation, they use the 7mm cold snare. They do allow to catch a very minimal amount of tissue. It's difficult that you catch the muscle altogether. Also, it's true that when there is fibrosis, there is no submucosa, so muscle is coming in altogether with the mucosa. So you need to have a certain level of skill and understanding how much you can suck.
Yeah, that I think is an important thing for people to keep in mind when they start using the cap technique. I will say, if you think that technique is transferable everywhere in the GI tract, if you put the cap out that far in the duodenum and suck, you're going to get a hole. And it's obviously it's very safe in the esophagus, and so just think carefully about that if you're starting to use this technique.
So can I just ask a question? So wonderful, this is exactly the kinds of polyps that most of us see. They're partially resected. And I like your comment, which is what we should emphasize to our audience as well, that these should not be sent to surgery. And now we have so many devices, and you showed a very, simple hot avulsion technique. And Alessandro, you talked about the cold snare. There's so many techniques. What are your thoughts about the newer endorotor device, which is which is now available for these scarred, fibrotic, non-lifting polyps previously resected? We have done a few cases, and as long as you stay with the suction at a low level, we've had some good results in suctioning this scarred and fibrotic tissue. So I just wanted to get your thoughts on that. I know it's not as easy as a hot forceps, but it's still a relatively technically not that challenging procedure.
Well, I'll be interested in what Al has to say. Also, I do think it has a little bit of a learning curve associated with it to use it correctly. It's a little, I've found it to be, can't quite always anticipate the speed that it's going to take tissue off and the depth of resection. So I just think if you want to use it, it's an alternative. I find that most of the time when I would consider using it, that some of the simpler devices will get the job done just as well. But I agree with you. And in fact, we have a recent ASGE tech committee review of a whole variety of devices, as you were saying, Mihir, that can be used to deal with fibrosis. So you're right that we've got an array of tools. I kind of think that for the average person, keeping it simple is maybe the best approach, simple and safe.
I agree with that. So let me say I love the device for the endorotor, and I think there is a lot of applications. It's difficult to transfer the expertise that you need to community GI, because you need to be very precise. And sometimes it's difficult to adjust the depth on how much you're doing. But I do agree with you. It's another great option. If you're able to use, can be extremely useful.
And Al, in your lectures, we didn't go into great detail with the full thickness resection devices. Are you not a fan of them? Do you feel that they have a role? Where do you end up in these types of situations?
Yeah, good point. I'm a fan of it, but Doug said before, so there is a size limitation. So if you look at your practice, how many lesions have you here? You find that are that small, and they do require at the same time full thickness. It's a quite unique situation. This is not common practice. because for indication for full thickness, it's a resection where you anticipate advanced histology. And it means it must be smaller than 20 millimeter, 25 millimeter with depression or P pattern, bad P pattern, anticipating advanced histology. But this is quite rare. In this situation, I love to do that. Sorry, it's my...
We'll let the dogs out.
Sorry about that. He's quite nervous with me. He wants to go out. So, no,
I think he's disagreeing with you, Al. I think leave the full thickness resection is the way to go.
It's not as good endoscopy as Doug, so he disagrees all the time. So the other situation where I'm going to use, where we have used it for lesion into the appendix. In that situation, full thickness resection device is very, very helpful and can make a very safe resection. Out of these two situations, I'm still struggling to understand what can be a broader indication for this device. And don't forget, if the lesion is to the right colon, advancing the device through a tortus or the verticular sigmoid can be tough.
Understood. Let's move on to the first polling question and get some comments from our attendees here and from our speakers. So we asked, which of the following questions is not true? And we had very good agreement from everybody who took the poll about the NICE classification and the ablation of the resection margins. The question section, or answer B, NICE type 1 lesions, NICE type 1 lesions are resected from the right colon with a cold snare, should always be clip closed to reduce the risk of post-resection bleeding. Most everyone thought that was a false statement. Would our expert panel agree that if you're using cold resection techniques, there's no need to clip close in a patient who's not going back on anticoagulation or other issues?
Yes, completely. Yeah. And in fact, if you saw the sub-analysis of Heiko Pohl's study, which is published in CGH, where they looked at even serrated lesions removed with electrocautery, there was not benefit in preventing delayed bleeding. The benefit actually arose with adenomas that were removed, large adenomas in the right colon removed with electrocautery. So now our current indications are proximal to the splenic flexure, 20 millimeters or larger, and an adenoma that is removed with electrocautery. You should consider clip closure. And then perhaps, as I said, expanding that, because we don't have good data on smaller lesions removed with electrocautery, where you have to go back on anticoagulation that makes you concerned. But with cold snaring, that's the real cost advantage, that you don't need to worry about delayed hemorrhage.
Go ahead, Al. You're muted, Al.
Yeah, I have a point on this, Doug. I fully agree on that. It's absolutely strange that when we did the meta-analysis, look into the impact of the level of protection of clips, it looks like that the left colon, even though you do a wide resection, they have a much less risk of delayed bleeding as compared to the right colon. Do you have an anatomical explanation on that?
No, I don't. I mean, it seems like we see lots of vessels in the submucosa in the left colon, but clearly there's a lower risk of bleeding. So I don't, but if anybody else does, I would be very interested to hear it.
No, I do not have it. It's curious and strange, but a present recommendation is just clipping into the right colon. You can see my dog is always
He's always disagreeing with you, Al. I don't know.
That's all right. That's all right.
Steve, can I ask a question to our expert panelists? So
Yes.
I think this question brought it up. I think Doug brought it up in his talk. Ale did as well. We talk about the NICE classification. Doug, you brought up the JNET classification. All of these classification systems are so integral to our colonoscopy practice in determining the management plan for these colon polyps. what do we need to do to ensure that these classification systems are used widely? So, Doug, I'll ask you a question. How do you train your trainees? Is it just on the fly when they're doing procedures with you to teach them these classification systems? What can we do better as teachers to ensure there's widespread adoption of these classification systems?
Well, Sasha, and I'm going to refer that question back to you because there's nobody better than you to answer a question about how best to educate people and how to do it systematically. But we do actually have a little bit of a training course that we use, and then the rest of the time it's really on the job training. We've been evaluating an AI program that will differentiate NICE 1 from NICE 2. And I've found actually that process of having the fellows first try to predict what the histology is and then see what the AI shows and then discuss it has been very helpful for them to learn the patterns, at least the more common patterns. It's always for a fellow other than the pictures. It's hard to teach JNet 2B and NICE type 3. There aren't as many lesions, but of course there are tons of opportunities to differentiate NICE 1 from NICE 2. So, but in terms of the larger educational issues, I should really have you answer the question, Sachin, because I know you'll be better at it.
Yeah, I'm still trying to figure this out, Doug. I'm curious to know, Ali, do you have any thoughts on this?
Absolutely. First, I don't know what is the US situation. In Italy and Europe, I would say 80% of colonoscopies, they do not report this classification. This is a problem. 0. So very little. And we still see, we are referring with the patients from many parts of Italy, from some part of Europe, and I do not remember single patients with appropriate classification of polyp, either Paris classification, JNet, CUDO, whatever. So this is an issue. So my forecast is in 2 years, the issue will be resolved thanks to AI. AI will bring everything down and will force everybody to report what AI is telling us. So right now, AI is telling neoplastic versus hyperplastic. In 1 year, we'll tell hyperplastic versus graded versus neoplastic. And in 3 years, we'll tell you the CUDO, the JNet very easily. At that point, with the AI-driven reporting system, we will all forced to write the report in the right way. Doug, you okay with AI?
Yeah, I think that's almost certainly true. And we're already seeing reports of AI programs that are getting quite good at predicting deep submucosal invasion, at helping to guide us when we should do on-block resection. I think we'll see all of that as Al is saying.
So Sachin, I'll just make a comment here that, I know that AI is coming and it's going to do, whatever we think it's going to do. But right now, to answer your question, it's not about training and trying to be making that diagnosis. The first step right now is there is no awareness in trainees that this needs to be reported. And I think that is the first step right now that we can do as trainers, which is start reinforcing the fact that when a lesion is seen, it has to be appropriately described with these classifications and not just that a polyp was seen, resected, and retrieved. Better, with the Barrett's world, Barrett's esophagus, 4-quadrant biopsies obtained. That is not adequate description. I would say the same thing, just creating that awareness where trainees should say this needs to be described and this classification needs to be done. I think that's the first step, and all other things will come.
Very nice. Let's move on to the second, one of the third aspects of that question. The first question is on this same topic, and that is, let's say you encounter a non-granular sessile lesion through 3 centimeters in size that has NICE type 3 characteristics. This has a higher incidence of submucosal cancer. Is that something we should be resecting? Should we be looking for the ultimate pathology proof that there's submucosal cancer? How should we pause on that lesion? Doug, you mentioned this a little bit in your lecture. Could you
Well, so my feeling is that the findings that we considered consistent with deep submucosal invasion, which would be NICE 3 or PUDO 5, these findings are not that sensitive for deep submucosal invasion, but they are very specific. They are highly specific. And so when you see those present, you probably should not be resecting the lesion for the most part. Now, maybe that's not true in a pedunculated lesion, but in a non-pedunculated lesion, and especially above the rectum, I think that this is not our biggest issue in colon cancer prevention. As people who do a lot of interventional stuff in the colon, we can get bogged down in these issues. Whereas from a public health standpoint in the United States, our biggest issues are benign polyps being sent for surgical resection. I think having colonic lesions that have deep submucosal invasion going for surgical resection is not an awful thing. Now, having said that, if the lesion is very small, we have some evidence now that deep submucosal invasion by itself with no other adverse histologic features may not predict lymph node metastasis. And so if you can remove that, I think especially with the full thickness resection device right off the bat, that's attractive. I think we'll increasingly see reports where there's a focus of deep submucosal invasion and people remove everything but that with EMR or something else, and then go to deep submucosal, go to the full thickness device for that portion of the device that is NICE 3. And then I think in the rectum, we're probably going to see more of this technique that Al was saying, where the intermuscular dissections in cases of overt endoscopic evidence of deep submucosal invasion is going to be more likely to give an R0 resection than ESD. But those are very, very sophisticated techniques. For the average person in the United States right now who sees NICE 3 changes, especially above the rectum, there is nothing wrong with biopsying that area and sending the patient to surgery for definitive treatment, especially in a good surgical candidate.
Dr. Rapici, do your Italian surgeons still operate, or have you?
No. I fully agree on that. Of course, this is tailor-made. There may be features of advanced histology which are in a large lesion, which are not totally depressed, so there may be space for resection. The main problem that we have right now is not what Doug said. I totally agree. These guys have to be referred to surgery. The problem is that our system to predict the lymph node involvement is based, the score system is based on very old data. So we do not know which patients they do really have risk of nodal involvement. So we need more science behind that, because I still believe that SM2 or SM3 invasion, G1, non-lymphovascular invasion, and a few millimeter, 1 millimeter distance from the resection still oncologically curative, because the risk of lymph node metastasis is almost nil. But we do not have data to properly predict the lymph node involvement. As long as we do not have that, we have to move to surgery a lot of patients with a negligible risk of having a lymph node involvement.
Great. I think we all agree. All right. I'd like to change gears a little bit here, and let's move on to the second teaching video. I'm going to ask Mihir to introduce this, and we'll go from this to the third question afterwards in the poll. Go ahead, Mihir.
Sounds good. So this is a patient I just happened to do this week, so I thought I'd include this in this RMIE session today. This is a patient who had a total colectomy for ulcerative colitis and an ileal pouch anal anastomosis. About a year ago, this was done elsewhere, so we don't have all the records. This was complicated, and the patient ended up with an ileostomy. And then there were more complications with abscesses and drains. And the patient then got really sick, ended up with having almost a permanent stoma because they closed off the efferent limb, and they surgically did the second operation and closed that off. And then the patient had a CAT scan with rectal contrast, which showed a fistula in the pouch. And so the patient was referred to our colorectal surgeons here at the university, and they asked us to take a look and see whether this would be something we'd be able to handle endoscopically. So I did this case, and you can see here I've started with a cap. This is just to highlight that sometimes these fistulous openings can be quite small and difficult to identify. So the cap really helps move folds and tissue and really delineate where the fistula is. So I'll start the video here. There we go. So we advance into the pouch. This is the tip of the J. Am I able to stop this video? There we go. Okay. There. So as we go to the very tip of the J, it's stopped completely now. Let me try to play it again. There we go. There's a little staple there, and there's what looks like an opening. So I put in an ERCP stone balloon and injected dye, and I saw the dye leaking, and I'm going to stop the video again here. Right, and I'll just explain a little more of the history. So we saw extravasation of dye, and then on further injection, it connected up to the upstream, or I shouldn't say upstream, into a small bowel-looking structure. The patient does give a history, and the day I met the patient said, I asked whether there's anything coming out from down below, or is it all through the stoma? And the patient said in the last couple of weeks, she was actually experiencing some brownish stool-like material coming from the bottom end, which was apparently the pouch was completely sewed off from the rest of the small bowel. So this seemed consistent with what the history was, that there was a fistula, and then it had been communicating with a loop of bowel above. So we decided to ablate this with APC, which you're going to see here. And I have advanced the catheter, the APC probe, and I'm not able to, there we go, play. And so we got it into the channel itself, the tract, and I ablated with APC and then ablated the opening. And after that, we decided to close it. And I'm going to stop the video right here if I can. Let's pause it. And again, once we've ablated the tissue, we have a few options. We can suture this. We can put regular through the scope clips. We can put an over the scope clip to try to close this. So maybe I can pause here and ask the panel here as to what they would do in this situation.
Doug, what do you think?
I have seen all of these things done with variable levels of success. So I would not have a strong preference, but probably either an over-the-scope clip or suturing, either one of those. Probably not through the scope clips. So either an over-the-scope or sutures.
So I would say that, I completely agree. And one of the points I want to make here is that it looks so beautiful once we do this and close this. But like you rightly said, it's the long-term success, which is the main question. And, I shared some of these studies with the over-the-scope clips. The immediate or short-term success is 80-90%. But then if you follow these patients, it drops to as low as around 50%. So that is something that, we need to talk to patients. And I think getting a contrast study the very next day sometimes is not helpful at all. I typically wait for a few weeks before we do it. But I agree with you. I think given the circumstances, the patient wasn't doing well. Our patient had already had 2 surgeries with a lot of complications. And our surgeons were also wanting to try to wait for some time before if they had to go back and operate. So something in the short term would be helpful. So I did decide to go ahead and place an over-the-scope clip. Let me play this again. And I do want to mention that there was a slight stenosis at the rectal anastomosis. And so getting the clip in was a little challenging, but we got it there. And once it's on the fistulous opening, we suction the tissue in, and the clip is then deployed to close the tract. And as I said earlier, it looks great when you've just placed it, but what the clinical outcome is going to be down the road, especially since it's communicating with the proximal bowel, which is going to be an ongoing source of drainage, that remains to be determined. So I just wanted to share this with you, that there are options. They're not perfect, but in the right setting may be helpful. And especially if you discuss with the surgeons and do it as a combined decision, I think that is a useful strategy.
Very nice demonstration to hear. Any preference for the over-the-scope clip, or you elected this because of its ability to capture the tissue, you thought, or what did you think?
Right. So I did use this clip. I don't think we have any data comparing the two types of clip, the Ovesco OTSC versus the padlock. I do think that from a technical standpoint, the padlock is a little easier to use. So that's an advantage. But whether one works better than the other, we don't know that as yet. Also, as I mentioned, there was a little stenosis at the rectal anastomosis. So even getting the upper scope in without any cap was a little tricky. So I thought this might be an easier way to do it.
Very nice. Well, let's look at our last question in the poll, and then we're going to be very close to the end of our time. Which of the following statements about colon fistulas and anastomotic leaks is true? We had good uniformity on the lack of SEMS stents closing the fistulas. There was also good uniformity on fistulas that, number C, fistulas that are closed at the end of the endoscopic procedure and rarely reopen. We talked about that. And Mihir, you nicely highlighted mucosal ablation, which is what we often use to facilitate the closure of fistulas, either with ablation with APC, or there's some techniques using either mucosal resection or even ESD to help the fistulas closure. So that's a true answer. And then what about endoscopic vacuum therapy? Is it rarely successful at closing anastomotic leaks within 2 weeks of surgery? It's not been our experience. What do you think, Mihir?
I wouldn't say rarely successful. I think it is moderately successful in the right setting, especially if there's no abscess or coexisting infection. I think the cavities, there is a good chance you would be able to close it. The data, there's very limited data, but it's about 40-50% closure, I would say, with this vacuum therapy.
All right. Any other comments from our lecturers? It would be nice.
With vacuum therapy, I think they are a great option. This is a great option for post-surgical rectal leak, because they're very easy to access, especially when the pararectal collection is impacted, it's huge. But always make sure the patient know that it takes time. And it's also not easy to bear the tube for the patients. So it's quite a complex situation. The patients must be aware that they may require about 3 to 4 weeks to get the leak completely healed.
Very true. Well, look, I would like to thank all of our lecturers for their outstanding presentations. The demonstration videos and the talks were fabulous. I think we've really focused on the art of organ preservation as it relates to the colon. And I sincerely thank you for your time and efforts. If there are additional questions for our lecturers, please place them in the chat and we'll have our staff get them to them via email or otherwise so they can respond. Thank you again for all your attention, and I hope you enjoyed our efforts today. We have one more break before our fourth and final session on the esophagus. please use this last opportunity to complete the conference challenge with our sponsors. And as a reminder, please close out of this tab and click on lecture session 4, esophagus, in the agenda tab to participate in the live question and answer and the polling features. To all of my colleagues, thank you and have a great rest of the day. We appreciate it.
Thank you. Great to see everybody.
Thank you.
Very nicely done.
Bye-bye. Bye-bye.